Thank you. I am very excited to introduce to you Dr. Dan Zhao. Dr. Zhao is an associate professor in pediatric rheumatology at Seattle Children's Hospital and University of Washington. Dr. Zhao completed his medical degree at Beijing Medical University in China. He obtained his PhD in nutrition sciences from Purdue University in Indiana. Following this, he completed his pediatric residency at Cincinnati Children's Hospital and fellowship in pediatric rheumatology at the Children's Hospital of Philadelphia. Dr. Zhao has been on faculty at Seattle Children's Hospital since 2013. He is the director of Rheumatology Ultrasound Program and the Clinical Chronic Recurrent Multifocal Osteomyelitis, and we call that CRMO for short, CRMO program at Seattle Children's. His primary research interest is clinical evaluation and care of CRMO. He leads the CRMO research group of CARA developing consensus treatment plans, ACR and EULAR classification criteria, and outcome measurements for CRMO. Dr. Zhao, I'll give it to you.
Well, thank you so much, Colleen, for your kind introduction and invitation, and welcome everyone. I heard we have radiology colleagues and orthopedics and medical students and residents. I think this is a disease that definitely can use the teamwork and team approach for us to learn together. So just appreciate the opportunity. Here is my disclosure. And the learning objectives are really to develop the differential diagnosis for chronic bone pain and to recognize some of the typical imaging findings of this disease, as well as applying all these into the initial diagnostic workup and from different disciplines. Eventually, the rheumatologist will be participating in the care and mostly the person managing, and also some updates from the clinical research. So I started with one case. It is a baseball player who was playing the catcher position and started complaining of the left leg pain. Thought had a stress fracture, and of course on X-ray, you can see some paraosteoerection at this diaphysis. The labs really was unremarkable. The kid didn't have any fever. A CT was obtained, and one of the concern was there is a small lytic lesion in there, and that led to the bone biopsy. And before that, MRI has been done. As you can see, there is a significant inflammation within almost the entire diaphysis, as well as the soft tissue and some paraosteoerection. The culture and pathology didn't show anything other than reactive changes, and it was just diagnosed as the healed stress fracture. So he was given an naproxen and had a good response. So continued medication for 3 months, everything is good, so stopped it and went on the physical therapy, returned to baseball. However, 6 months later, came back with a right arm pain and swelling. And there are two concerns. One is, could this be the DVT, which is uncommon in this place? They did a Doppler that shows no clotting. Also had the other labs. Could this be an infection? But this is the second bone. So the MRI is the next step. And again, similar changes. It affects not only the diaphysis, but also extended to the metaphysis in the distal with some paraosteo changes. And also the bone scan, I didn't have an image here. It showed increased uptake in both the femur that has been affected as well as the humerus. So there are two spots. So the differential diagnosis at this point, one is the infectious osteomyelitis, despite the patient didn't have any abnormal inflammation markers or fever. Malignant bone tumors, and but it's on two different spots. LCH can definitely give you, but the typical location will be spine or skull, or inflammatory bone disease. So does he need another bone biopsy? And we decided not to, and it will give him the diagnosis of CRMO. It is based on the multifocal pattern. And also the bone biopsy has been done on one of these affected bones that didn't show any malignancy or infection. And otherwise, and he was pretty well appearing, and he had normal lab values, which didn't suggest any other mimicker diseases. So it is first described about 50 years ago as a symmetrical multifocal osteomyelitis. And it's a sterile, primarily affecting children, but has been reported with adult onset. And we'll talk about the namings. Unfortunately, it doesn't have any confirmatory biomarkers from pathology or imaging. And this will be one of the goals in that we want to develop someday that will have a disease marker. And when they were first presented, these are the diagnoses often they were given. Of course, the infection is the number one, and growing pain is another common cause. So every time when I was talking to a pediatrician, many pediatricians have told me during their career, they look back and they can think of a few cases might be CRMO, except they have not gone through all the workup. And malignant tumor is always on people's mind, and that's one of the most common reasons for them to go to the ortho bone tumor surgeon and get a bone biopsy. And how common is it? It's considered as a rare disease. We'll talk more in Germany how common it is, but the mean age at diagnosis is about pre-puberty, so 9 to 10 or 11, and more affecting more girls, and majority are Caucasians, but I think also depends on the geographic location. So we definitely need more information from the other research on this and to find out the true prevalence. So in a German registry, they have found about 4 children per million every year with a new diagnosis. And that was reported more than 10 years ago. Since then, the UK group has reported the influx of the new cases once they sent a letter to their orthopedics. And we have seen something similar as well. Here is the report from our German colleagues. Just the antibiotic usage has dramatically decreased after their discussion with their ID group and recognition of this condition that can start the appropriate treatment for these patients early on. So here is some data from our area. Seattle Children's cover 4 states, WAMI area in Pacific Northwest. So we have a large catchment, and however, the number of cases were only 3 to 5 per year between 2004 to 2008. And you can see how it has increased over the last 4 to 5 years. And when we divide it into the 2 groups, the last 4 years has about 3 or 4 times more cases every year. And likely because of the awareness has been increased and because of the collaboration we have had with our other colleagues, including ortho, ID, oral surgery within our hospital. And the names can be confusing. As you can see, there is a long list. And the ones I want to point out are the SUFFLE, which is more commonly used by our adult rheumatologist colleagues, and it has more cutaneous involvement in addition to the bone inflammation. CNO, which is on the bottom, which is more of the umbrella term. So it doesn't specify you need to have recurrent course or have multifocal distribution. And in terms of the bone involvement, here's the whole skeleton. As you can see, the lower extremity is the most commonly affected site, followed by pelvis, clavicle, and spine. And within the spine, T-spine is the most commonly affected sites. And back to the name of CRMO, unifocal versus multifocal, it has been controversial because about 30% of the cases at presentation will have just unifocal, although most of the reports have not used whole body MRI for every new cases. So that make us question whether the 30% is an overestimate. I didn't have the data included here, but we just finished analysis of about 60 cases using the whole body MRI at the beginning within the first 3 months. We saw similar numbers, unifocal about 30%. But in another study from our German colleagues, they have seen almost 95% have all multifocal presentation. One of the challenges, as we are going to talk about imaging, is the definition of a lesion by radiologists varies a lot. And on the left side is the data from Eurofever registry our German colleagues have led. And again, you can see the similar numbers that about 30% had unifocal. Sorry, one point I forgot to make is that after they were observed for 4 years, ones who had unifocal at the beginning eventually developed multifocal presentation. So that's why the multifocal, if we don't treat them enough, eventually that's where they're gonna be ending at. And the next feature is the recurrence. So here is a study from Christian Hedrich's group. So they have about 50 patients who have been treated with NSAIDs. They followed for 2.4 years, and on average, 50% of these patients would have at least one flare. And then the complete remission rate was pretty low at the beginning, 23%, and then it reached about 50% and hang around there. So it tells us, one is it's highly recurrent, and second, NSAID alone is not going to be enough for at least half of the patients. They need further treatments. So hence the CRMO, the nature of the disease, if we are not picky on the term, I think is more appropriate. And when should we suspect the CRMO? So it commonly presented with the focal pain that can come and go. And sports participation may be affected, and that's tricky because some kids don't complain of pain, just like arthritis. But in the sites where there's not much of the soft tissues, the mandible, clavicle, the distal tibia, fibula, where at the ankle, often you will see some of the swelling, feel some warmth, and there will be the tenderness. But many have a normal exam, and that's why our parents are calling this invisible disease, and that's why there is a delay of diagnosis until someone order an MRI. So the history is important. We talk about a pattern as waxing and waning, but sometimes it can be constant once it reaches a certain point. The pain is described in different ways, and some patients say they just know that it's a Crmo pain. The other histories, including the GI symptoms, because the IBD could be associated with this. I haven't had any patients with CRMO diagnosis first, later developed IBD, but most times it's in the IBD patients and who started having the bone pain, and we do the MRI and found out they have CRMO. Of course, cutaneous changes such as the severe acne and psoriasis, pustulosis. The family history is important, but it's not a guarantee. And as we're going to talk about classification criteria, it has some weight, but not as much as the first two. Of course, when we see any constitutional changes, we need to think about this is not CRMO. We should exclude the other things before we commit to this. And other metabolic or genetic bone diseases, such as hypophosphatasia. This is very important to ask the premature loss of the primary teeth, any family history, and just the cultures that is extraordinary. So here's another case, and that was seen by me, and the patient had a Crohn's disease and continued to complain of the leg pain during the night, but does respond to the Robin and Tylenol. CBC, CRPS are normal. Of course, I check all the joints and gave the kid diagnosis growing pain and sent the kid discharged from clinic. After 3 years, came back to me. Their persistent pain and it has extended to other places. So finally, I ordered MRI and this is what I got. Can see the symmetrical hyperintensity within the epiphysis and metaphysis of the proximal femurs, as well as in the ilium. So this imaging pattern will be consistent with CRMO. Therefore, the patient was diagnosed with CRMO, and bone biopsy was not needed. We had more confidence because the chronic course, and also the underlying Crohn's disease, and also symmetrical multifocal distribution. So another patient, this girl had a history of periodic fever, PFAPA, and after that was resolved, she developed psoriasis, has been treated with methotrexate, not responsive, topical did not work, put on the etanercept. A few months later, she developed elbow and hand pain. She also had normal CBC, except a little bit left shift in 7% of the band, but ESR was normal, CRP just mildly elevated. The X-ray did show some para-osteo reaction here, as the arrow pointed out, in the metacarpal bone. And also the elbow has the distal metaphysis lesions. So she got a bone biopsy, and that showed fibrosis and chronic inflammation. And we rule out LCH, so she had the diagnosis. And the hand involvement is not common, but can be dangerous. Unfortunately, this patient's growth plate fused, so she had a short third metacarpal bone, which may need to be surgically corrected at some point. So from these three cases, and we can see some of the patterns. One is it's subacute, it's chronic, but occasionally they could have acute worsening. And we do have patients who presented with fever, high inflammation markers, that was concerning for infection, for malignancy, and almost all these patients got biopsied and they ended up as a CRMO. So we see some different spectrums within this big umbrella. The inflammation markers mostly are normal or mildly elevated for those who otherwise did not have the acute fever. And other autoinflammatory diseases, such as IBD, psoriasis, as we have talked about, are highly associated with this condition. And here are some of the percentage from the survey of the parents and also the physician's reports. So just a couple of quick slides, and thanks to Polly Ferguson, my mentor from Iowa, for sharing this. And she has been the leader of all the genetic research for this disease. One of those discovered by her lab was the FBLIM1. The index case is a girl who had CRMO, also with psoriasis at age of 8. The genetic testing found to have the homozygous mutation of this gene, which make it not functional. So the mechanism is to increase the RUNC ligand, therefore increase the osteoclastogenesis in bone resorption. And she subsequently screened from her own cohort, 100 cases. It's not as common, it's only one case, so it's 1%. So it doesn't explain the majority of the cases we're seeing. And here's some mechanism about how a mutated FBLIM1 would lead to the increase of RUNC ligands and therefore more bone resorption. The other forms are affecting relatively younger children, mostly under age of 3. Majid syndrome, discovered by Dr. Majid. They will have triads, so recurrent fevers. They also have the early onset of CRMO and the severe anemia that will require transfusion. Their cutaneous lesions are common as the Sweet syndrome. If you biopsy, you see the neutrophils. This is an autosomal recessive, and there is a gene testing for it. It's part of the periodic fever syndrome gene testing. And treatment is going to be targeting on interleukin-1 because LPIN2 is the gene that has been affected. It regulates the production of interleukin-1, and when it's not functional, it will lead to the increase of interleukin-1. And indeed, in the clinical trial, they have seen the success, which is not a typical treatment we would use for CRMO. So it's very important to distinguish some of those monogenic syndromes that have the chronic multifocal osteomyelitis presentation. The last disease is called DIRA, so deficiency of interleukin-1 receptor antagonist. Basically, these patients are missing anakinra in their body, and they have really early onset as neonates. You can see all these pustulosis, and also within the bone, the periosteal reaction and enlargement. And this also mimic the CAFE disease, where the patients will have collagen 1 mutation in what's similar, except in the CAFE disease, they don't have all the skin cutaneous changes. So of course, the treatment is very easy. Give them anakinra or canakinumab. So just blocking the interleukin-1 cascade. And this work was done by Rafaela's group in the NIH. And also there is gene testing for that as well. So for patients who had multifocal osteomyelitis, inflammation, we need to think about these cases, and especially when they're under age of 3. And these are rare, so it doesn't explain the majority. But Polly is still working on the whole exon sequencing. We're hoping to have a multi-panel genetic marker that may give a higher risk for certain cases who are the majority of the patients. So the lab testing, we routinely send all these testing, and the goal is not really ANA B27 to add more weight to confirm this is CNO, but just further characterize them. And the other testing that we do, such as vitamin C, calcium phos, PDH, or alkaline phosphatase, are mostly to rule out the other diseases. And of course, if a patient had elevated LDH uric acids and big swollen lymph nodes, and you have to think about to get the marrow and lymph node biopsy. And we routinely send the infection workup. Some could be the blood culture. Of course, if you have a bone biopsy, these should be sent out. So one of the thoughts is to monitor disease or diagnose the disease, since there are bone resorption markers, and it's one of the common pathway for CRMO. The N-terminal telepeptide has been invented 20 years ago by one of the colleagues here in UW, David, and we had a chat, and could this marker be used to help our diagnosis and disease monitoring? So one paper from the Pathology's group in Canada, they have looked at the NTX levels from these patients, especially those who have been treated with pimeginate, and they have seen some uptick of the NTX once they have the flare. So the question is really for us, is the focal inflammation with active disease associated with the urinary NTX? And is it different between children with active CNO and healthy children? So that will serve as a screening marker for us. So Polly and I did this small study funded by CARA. We compared the healthy control to the patients who have active CNO and with by age and sex matching. Unfortunately, the noise is too great that we didn't see any of the difference between the two groups. And then within the patients, we compared the levels of NTX when they had active disease versus when they have remission. And again, it didn't show any difference either. So it is a little disappointing. I think the possibility is, even though many patients have multifocal bone inflammation compared to the whole skeleton during a high turnover states of their life, the signal is not big enough to be captured. So we may need to use other technologies such as the mass spec and to look for more specific markers. So now we're going to switch the gears and talking about the imaging findings. And of course, the X-ray is always the first line of the imaging. And typical changes at the beginning, many will have lytic lesions. And afterwards, their osteoblast activity will catch up with rebuilding. You can see the sclerosis, and there could be even periosteoreaction, hyperostosis, the overexpansion of the bone. And for those who are not treated, they could have a mixed picture. So it's lytic lesions combined with sclerosis and hyperostosis. The MRI is the imaging modality to go for CRMO because of the following reasons. And first, it's the most sensitive one. And it's also can cover a large area. And I'm glad to hear that your hospital already have the whole body MRI set up. And I think that really help us to capture the patients much early on and make the diagnosis easier. And normally you don't have to use the contrast because the joint effusions can be seen as stir imaging as well. And often we'll have to talk about if your concern is of infection and malignancy is really high, probably you want to give contrast for a regional MRI and then followed by a whole body screening without contrast and to see if you have other spots. And of course, comparing to the bone scan, which we have been using for many years until 5 years ago, it has radiation. So MRI is much safer, except the younger kids may need sedation. But remember what we talk about, the onset is about 9 to 10 years. So most of the patients will be at an older age, they will be able to do the MRI without sedation. So on the MRI, this is the typical findings. You can see these patchy, homogeneous, poorly demarcated signals, and it's symmetrical, and mostly affecting in the long bones of the metaphysis. And you can see both metaphysis and epiphysis. So it's across the growth plate. The diaphysis, the middle part of the long bones, can be affected, but often we'll see that continuation from the middle part of the bone to the end of the bone. And comparing across all the imaging modalities in physical exam, and you can see using MRI as a gold standard, physical exam can capture about 30% of our patients. And X-ray is really lousy, only 13%. And granted, if you waited long enough, maybe after several years, you'll be able to increase that number. But this is the exact reason why the X-ray is not enough in order to early diagnose these patients, and we need to do the MRI much sooner. The bone scan has about 74% of sensitivity rate. And here is a typical example why bone scan is not good for this disease monitoring or diagnosis at the beginning in kids, because the growth plate will have increased uptake of the tracers, and it's symmetrical. So there is no way for you to tell. Maybe there is a slight increase in this knee compared to the other. But in MRI, indeed, both of them had inflammation. So this patient now on the bone scan, you will comment there is possible 1 lesion or 2. If you were to give this on the MRI, there will be at least 8 or more than that. So, and also the whole body can be done really fast. And the typical sequence, what we do, this is the protocol shared by Shang and also Polly from Iowa. We divide the entire body into 4 or 5 stations from the coronal stir, and then 2 stations for the entire spine on the sagittal view. And this does help us to discern whether there's a true vertebrae lesion or not. And also we have a sagittal view of the ankle. And this is very important because the foot can have involvement in about 20% of the patients. The typical Crmo view doesn't include visualize it well, so the sagittal is needed. Because pelvis and knees are commonly affected, we added an axial plane for that. And in this patient, you can see there is a proximal tibial lesion. And of course, it has a very rich information in there. So we had a group of international radiologists who are experts in CRMO to get together in Seattle and determine what will be the grading for each characteristics, including the hyperintensity signal and also the signal size using a relative comparison of the entire bone. And also just dichotomized grading for soft tissue involvement and bone expansion. This is an example for a mandible lesion. As you can see, there is soft tissue involvement and significant bone enlargement. So the next step for this work, and Dr. Inselico, a colleague from Italy's group, has taken it further by for each affected lesion, give a numeric score, the total score, based on the involvement of the soft tissue bone expansion, and then tally all these up together to give you the whole body score. And they have found a good correlation with physician global assessment. So the higher the value, the more severe disease physician I think the patient has. And also in those who have higher numbers or higher MRI scores, more will have functional impairments and higher inflammation markers. So the next step is to validate this tool in a larger multi-site study, which we just submitted the grants to NIH this year. So now we're gonna go back and we know quite a bit about CRMO. So let's think about what other things that we must keep in mind. So the imaging itself is not completely diagnostic. And these are some of the cases that could look like CRMO, but they're subtle red flags that were caught, and they have extra workup and allow us to finally find the true diagnosis. So this is a 6-year-old, 1 year of intermittent bone pain, and classic spots, the swelling and pain in the right clavicle, but also from the whole skeletal survey, you can see the right and the left femur also had some of the abnormalities, and had an MRI and confirmed there is hyperintensity. What is making us worry is how lytic the lesion there is. It almost looked like there is a big hole in there. There's a well demarcation there. The labs are not helpful. They're normal, including LDH and inflammation markers. And we insist on having the bone biopsy and turn out to have the LCH. So I'll say LCH is probably the number one differential diagnosis in CRMO, because they can have the multifocal and can affect the commonly affected bone sites in CRMO. And the next case, this is a 4-year-old who had hip pain and also the shoulder pain. Did have intermittent fevers. The X-ray and MRI showed multifocal osteomyelitis. He did have the elevated ESR and CRP. CBC was fine. I did have good response to NSAIDs. So we have to be careful. The response to naproxen or leave is not diagnostic, because the infection could have good response, and so is malignancy. And the MRI findings is a little concerning. You can see it's not as homogeneous a signal as you would expect. And on the CT of the spine, you see more sclerosis in here. So this patient turned out to have the neuroblastoma through the bone marrow biopsy that confirmed it. And of course, other urinary screening tests has abnormalities. So for the little kids, multifocal and with the concerning signs, neuroblastoma will be one thing you want to keep in mind. So the next case is a 10-year-old who's a picky eater. So that may give you the clue. Presented with 2 months of the knee pain, and it's mostly nocturnal. And the activity also increases the pain. The blood work is normal. The X-ray showed something as presented here, there was a little beaking, there's some thick sclerotic metaphyseal lines. So when we send the vitamin C level, it was undetectable. This is scurvy. And our center has published a case series. We have almost 10 cases. I think always ask the dietary history. And this is our routine test we send. And then one thing to keep in mind, it needs to be protected from the light of the sample. Otherwise, it will not give you a true result. And also, if the patient has already received one supplementation, the level could be normalized. So the next case, this patient had a clavicle lesion, but there is a huge mass in there. So the clavicle involvement itself is not enough just to give a patient diagnosis of CRMO. So this patient turned out to be a Ewing sarcoma. In another case, the patient had episodic knee pain and swelling. It was really painful that he was banging his head against the wall. But after 2 hours, and he's fine. He's walking, he's playing. Exam, there's no sign of arthritis. X-ray was normal, but high inflammation markers, LDH, uric acid, and CBC, they were all fine. On the bone scan, we saw this increased uptake in the distal femur. We're about to refer him for a bone biopsy, but he had another severe pain, ended up in the ED, had a third CBC that showed blasts. So this is pre-B cell ALL. So that can give you those type of presentation. And another patient who had the leg pain for about a month, had normal exam, had inflammation markers mildly, moderately elevated, but CBC was unremarkable, treated as infectious osteomyelitis. So before referring to me and we talk about the bone biopsy will probably be helpful. Due to the distribution of the lesions, it's solely diaphysis. And the difference between this one and the index case I presented at the beginning is you can see some of those very heterogeneous of the signals. Unlike our case, which is more homogeneous, the whole thing is lighting up. So the biopsy turned out to have the osteosarcoma in this patient. And again, just all these cases are telling us the imaging itself is not enough, that we need to complete all the lab work and always keep the other mimickers on the table when the patient doesn't respond to the standard treatments as we expect. And bone biopsy can be really helpful. And this is the last kind of mimicker case, relatively young, the 2-year-olds, as we talked about, under 3, you should always give a second thought, is this really Crmo or not? And this was the case. We did the first consult through the telehealth. There was warmth of the right knee based on family report. The inflammation markers and CBC, they were normal. And we had a concern for something else because the history showed she has lost the baby tooth really early on. So hypophosphatasia came to our mind. MRI did show some of the abnormalities. So we sent the alkaline phosphatase, which is the generic screening. It was low for that age. So PLP is really high, which is marker as the vitamin B6 derivative. So one of the things challenging is it doesn't have a diagnostic marker, and how can we classify all these cases correctly for the future research? And hopefully one day we have well-tested diagnostic criteria. There have been 3 proposed. So it's an international collaboration that involved many collaborators all over the world. And this was presented at the ACR last year. About 450 cases, and include majority are CRMO, 1/3 were mimickers. We're using the prevalence ratio, so how common each feature is present, comparing CNO to the mimickers, to tell us whether it is more for CNO diagnosis or classification or against CNO. And there is a special software mechanism to include all experts and also patients, parents, representatives, led by Ali from New Zealand, and over the weekends during the summer. So we had this work almost completed. And here listed all the candidate domains, and from the heaviest weight on the top to the lowest. So LDH, a normal LDH, was ranked the highest. And mostly because for most of the CNO cases or CRMO cases, we rarely see an elevated LDH unless they have other coexisting condition. And this is likely to be added as an exclusion criteria. And the specific bone sites, including clavicle, mandible, and also the pattern, it's multifocal or symmetrical, and they're on the top of the list. The other items, such as poor response to the antibiotics, the bone pathology, mostly the chronic inflammation and fibrosis, and also age, they're about 3. The coexisting conditions, such as axial arthritis, not peripheral arthritis, and psoriasis, IBD, and could have normal hemoglobin or mild anemia. The other items can relatively carry less weight, such as absence of the fever. Just as we talked about 20-30% patients may present with fever, and they may also have elevated ESR CRP. The family history and ESR platelet ratio, they're likely to be cut out from this because the weight is very trivial. So we're hoping to finish that work and to validate in another 500 cases we have collected. So stay tuned. And in the clinical management, it always will come up, do a biopsy or not. And there is no universal guideline, and everyone has a different set of the criteria. These are what's brought up by our radiologists through the surveys that Frazana and I have done. So if you see the disorganized bone formation, if you see these moth-eaten appearance and big chunk of lytic lesions and there's soft tissue mass, it's always a good idea just do the biopsy. And it's still controversial for the unifocal lesions. Should you biopsy or not? I think you have to judge case by case, and depends on the need of the treatment. If the patient is doing well on naproxen with a full resolution of the lesions, then you probably don't need to do it. And this is a very complicated kind of diagnostic algorithm that we developed in Frazana. I think it will be published soon. I'm not going to go through the entire thing, but want to emphasize there is a few crucial decision points. First is whether there is a red flag. If there's a red flag, I think you're better off with a bone biopsy. And of course, also whether they have the common coexisting conditions, which give you more confidence. But again, in those, if they have the red flags, you probably still want to get a bone biopsy. But for those you have a suspicion of metabolic bone diseases or dietary, you could spare them. And it's good to do these screenings just for all the patients. And of course, we need to collaborate with the orthopedic surgeons, our IR docs. In our hospital, the spine biopsy is done through the IR just because of the risk, but everywhere else is done by our oral surgeon. By our orthopedic surgeon, except the mandible will be done by the oral surgeons. So I want to talk a little bit about the bacterial cultures and what can you find. It has been reported the P. acnes in about 50% of these bone biopsies, and also the most common CONS could be contamination. Actinomyces, commonly seen in the mandibular bone biopsy. So the best way is to collaborate with your ID doc and to figure out whether you need to go on a short course of antibiotics, or you can watch them closely while you start the initial treatment for CRMO. The PCR has been done in many cases in other reports, and it has been reported inactive. And the pathology findings depends on the phases. At early phases, you can see more of the neutrophil, the most becoming the lymphocyte infiltration later on. And then you can see the fibrosis once it starts the healing. And the long-term prognosis depends on the child. So the only study that was done is following them for 15 years and brought them back and do a whole body MRI as well as the physical exam. And it's a small study, only 17 patients, but you can see that about 50% of them still have active lesions and 50% of them will still need to take medications. And here is the example of the vertebrae and also the pelvic lesions. So the message for our families are that they do need to continue to see the rheumatologist once they reach adult age, and they may need the imaging monitoring periodically. And some patients will unfortunately need to take their medications for a much longer time. And our goal is to be able to identify them early on so we can inform patients much better and to implement the precision medicine. So what if you leave it alone? That some patients ask, maybe after they finish the growing period, it will be just done and gone. Well, there are consequences such as the leg length discrepancy or the angulation of the leg that will require some surgical treatment, and also the deformities of the spine, the kyphosis. The spine lesions, they collapse really quickly. I think part of the reason is the children, they don't stop playing even though they have any of the pain. And they jump, they play with a monkey bar, they fall, they wrestle, and that will crash the bone. I have one child who told me that her 5-year-old brother just did a karate chop on her back. And after we did MRI, we found the crushed the bone of the T-spine. So I don't think that 5-year-old's karate chop was that powerful. It was the CRMO that has crushed that. So for all of our patients, if they have active spinal lesions, I will restrict their physical activity, no jumping, no axial loading, until their repeat MRI has shown complete resolution. That means the signal has disappeared, although the height loss will not completely recover. So the last part, I want to talk about the treatment. Colleen, how much more time should I can pause here? Or?
You have 10 minutes. Maybe if you can go through some of the treatment in a few minutes. Yeah.
Okay, couple of minutes. I'll be very quick here. So the NSAID is the first line, and it was well done by Christian Hedrich's group in Germany. You can see it's 10 years ago. But again, for the 70% in response, we can only reach about 70% of the patients. So there is at least 1/3 of patients need more than NSAID treatment. And therefore, we developed this consensus treatment plan within CARA, the DMARDs, which includes methotrexate mostly, the biologics such as the Humira, Remicade, and bisphosphonate. And the goal is to test it out in a prospective observational study, which we have started. We call it QUIRE registry, which is international. We're quite ambitious to enroll 2,000 patients, and then with 5 years of follow-up. Right now we have 220. After 3 years, hopefully we're going to get it there one day. So the goal is to evaluate if one treatment is better than the other, and also if the disease will more likely to flare after you discontinue any of these. And that would also add the rationale to choose your medicine. And how do the physicians use these medications, and whether there is any initial characteristic we can identify and help inform the patients what their future path is. And this is the clinical disease score we developed with 3 components. And when we lump all these second-line treatments together, we can see a significant decrease, but they are not turning to 0 for the pain, patient global, or total number of lesions. And I just want to acknowledge all of my collaborators. This is my team, everyone's hard work, and for all the research that we're doing, including our patient and parent representatives as well. Thanks so much for your attention, and happy to answer any questions. I'm going to stop sharing.
Thank you, Dr. Zhao. That was excellent. I have a question to start with, in particular regard to treatment. So is there a length of time that you do keep patients on treatment if they seem to be responding? And does it matter if they're on like a biologic or if they're on something else like a DMARD? And kind of how do you talk to families about that? Because that's a big question that we get.
Absolutely, that's a great question. I don't think, Colleen, that we have any consensus on that and have any data. In general, for the NSAIDs, I'll tell my patients based on Christian's study, I'll say 2 years is the target. Of course, we don't know if you treat them longer, you can necessarily prevent the flare. And his data clearly suggests that 50% will still have flare. But my experience is that for those who only need NSAIDs, most of them are doing well if they continue to take it. And the other thought or question is whether by treating them longer time with NSAID, that you can prevent them from needing second-line treatments. And that needs to be further tested. For the DMARD or biologic, we are using similar guidelines. And if they need biologic, majority of them, when we try to take them off and they do have disease flare, unless we're using the DMARD, such as methotrexate, as the maintenance treatment. So I have some really sick patients who needed all 3 treatments early on. And when they are off all medications, they'll still have a few of the spots kind of coming up. But if they stay on the methotrexate, and they're perfectly fine. So that may make us think you can treat the disease as induction and remission maintenance as well, similar to how we treat vasculitis or lupus. That may be another way to think for the sicker patients. But for permanganate, Ron Lexer has taught me the most, and I think our European colleagues usually more. Some countries, they would just commit the patients to 2-year treatment plan. I rarely do that. I probably have maybe 1% of the patients who need it that long. The majority patients will need somewhere between 3 to 6 months. And 12 months will be for some patients. So we always reevaluate by the MRI clinical visits and to inform them. So I think 2-year commitments from these countries is likely due to the poor access to the biologic. They couldn't combine it as much as we can do it here.
Thank you. We've got a couple questions coming through here too. So one is from Sean Mahmood, who's our pediatric rheumatology fellow. So he asked, have you found scurvy patients mimicking CRMO that surprised you? In other words, in patients that have reported a relatively normal dietary history, could we screen for scurvy with dietary history alone, or should we be drawing a vitamin C level on all patients being worked up for CRMO?
That's a great question. I have been surprised before. I think it's the validity of the dietary history and how much you can get out of that. I think most of these you can trust in what they're telling you. But it's, as I said, it's a routine workup because I have this panel just send all of them. From the classification projects, we have found vitamin C deficiency, these cases, applying our criteria, it's really difficult to distinguish because it can have the same type of biopsy findings. The lab's mostly normal except the vitamin C, which is not part of the criteria. So that was more added in the exclusion criteria. So my recommendation is to talk to your lab and make them aware if you're going to start screening more for the patients, make sure the sample is collected and stored correctly. And you may be surprised in capturing some of these patients. And there are some patients, I may treat them as both vitamin C deficiency and Crmo, just because their imaging findings will more fit for CRMO, but they happen to also have a low vitamin C deficiency, which needs to be addressed anyway, because they could have gum disease and other manifestation as well. So I'll give them the permanganate along with the vitamin C.
Great, thank you. We have another question from our other pediatric rheumatology fellow, Allie Learman. She says, you mentioned family history is a poor indicator for the diagnosis of CRMO. Are there any conditions that still raise your suspicion for this? For example, psoriasis, axial arthritis, or IBD?
The family history?
Yes.
The family history will carry some weight, but without the bone lesions and other things, it can only be useful. It's not as useful as the patterns of the bone lesions based on our classification criteria. So once we finalize all the weights, to give you a relative comparison, the multifocality or the specific bone site, out of the 100 points, and these will carry somewhere 15 points, and then the family history will be just 1 point. So the weight is only 1/15.
Thank you. We have 2 minutes. I do want to ask this one question Mona Riscala asked, because I was thinking the same thing. So she's asking, with regard to sacral ileitis, do you feel that the distinction between periarticular enthesitis / bone edema versus CNO, and can this be distinguished on MRI?
The sacroiliitis. Sorry, I couldn't see. So the CNO, I would say there is overlap between ERA or ankylosing spondylitis in adults and CRMO or CNO. That's why the axial joint involvements will add more confidence to the diagnosis of CNO, because they also will have in the spine or other parts of the lesions. It depends on the distribution of the lesion. If it were straightforward CNO, you can see the involvement just one side of the joint, so either just ilium or just sacrum and the spur of the joint. But if it were to overlap, then you will see the across the joints. I don't know if that answered the question. I may have not got the question correctly, Colleen.
I think so. I think we see it quite a bit where there's, a lesion in the sacroiliac area, and trying to distinguish, is it sacroiliitis? Is it CRMO? Does it matter? We kind of treat them similarly.
Yep. So I would say the treatment for those with the ISI parts of the involvements, always go with the biologic. So the treatment is not going to be that much of different. And I think I would give them both diagnoses, because that's what imaging will suggest. And I have seen some of the patients with initial just the sacral or ilium involvement and developing erosions into the ISI joint later on. So I think some patients may have a evolution just continue to evolve.
Thank you. Should we had one more question, but I know it's 8:30. So
yes, I'm quite strict about ending on time.
Okay, sounds good.
I just want to remind everyone to please register your attendance. I'll have our coordinator put the code in the chat again, and please also evaluate today's session with the link that will be put in the chat. Thank you so much for being here with us. I will go to my general peds clinic today and feel nervous about all the children with growing pains.
We have Colleen there. You can talk to her. Well, thank you so much for having me.
All right. Thank you so much.
Thanks, Dan.
Bye-bye.
Bye.